Hello, everyone. Thank you for joining us today, and thank you for your patience with our brief delay this afternoon. Please note that today's session is being recorded, so if you have any objections, you may disconnect at this time. So thank you very much on behalf of the National Cancer Institute. I wish to welcome everyone to today's Implementation Science webinar. We are excited to be joined by our speakers, but before we get started, I'd like to give a brief word about logistics. We ask that if you are not already on mute, to please keep your phone on mute for the duration of today's presentation. As mentioned, this session is being recorded, and muting all lines will help us avoid any background noise. We do encourage questions, and they can be submitted by using the Q&A feature on the right-hand side of your screen. You can type in your question in the provided Q&A field and hit submit. Feel free to submit your questions at any time during today's presentation. And with that, I'll turn it over to David.
Thank you so much, and again, apologies for the delay. Every once in a while we have those unexpected technical challenges, and this happened to be one of them. So hey, we roll with it. I'm so excited, first of all, to welcome everybody, and secondly, to talk about the overall view of these series of webinars. We've seen the opportunity at the NCI recently, in recent years, to really focus on implementation science as one of a collection of priority topics within the Cancer Moonshot. And so this is a chance to learn from our wonderful experts. You can see their faces in front of you. And really talk through some of the linkages between a particular initiative that was stimulated through the Cancer Moonshot and our broader field. And we're so grateful for all of you for tuning in. So just to give you a sense of what we're going to do, I'll give brief introductions to JD and Sandy. We'll turn it over to them so that they can focus on orienting everybody who might not be as familiar with this particular initiative, the IMPACT initiative. And then again, we'll get more into our typical sort of fireside chat, back and forth discussion. So as always, we appreciate your questions. As always, we appreciate your attendance. And I'm so grateful to be able to turn this over to Sandy and then JD. You'll see just in order of who we've got with us. JD, I met during our shared investment in the TITRE course. So TITRE, the Training Institute in Dissemination and Implementation of Research in Health, for Dissemination, Implementation, Research, and Health. We ran for 9 years at the NIH level. JD was in, I think it was the 2013 cohort, which was the third year of TITRE. And we were in the same small group. And so it was, I think it was group 1, if I remember correctly, JD. And it was a great group, as were the other groups. But seeing JD, who has done a lot of work in mental health, has really expanded that in recent years to focus on symptom management and cancer. So great to have you with us. And then Sandy Mitchell, who I was able to meet when I first came to the NCI from NIMH in 2014. Sandy was one of the first people who I got to know, both from her expertise as a clinician, her interest and expertise in implementation science. And a few years later, at the ASCO Quality Care Symposium, Sandy and I had the pleasure of joining Sandy for a plenary session where we were really thinking about how do we align quality improvement, how do we align implementation science, how do we think about how it can influence the quality of care, of cancer care for folks. And so it's great to have Sandy here as well as JD. So I'm going to turn it over, I think, to Sandy, who's going to just walk through the orientation, as you can see here, the slides. And then we'll pick up the discussion after that. So Sandy, you want to take it away?
Absolutely, and thank you, David. And on behalf of JD and myself, thank you for the really kind introduction, and thanks to the Implementation Science Group for organizing these fireside chats, the chance to showcase some of the initiatives that are beginning now to come to real life and to lumber along from the Cancer Moonshot. And so today, JD and I are going to be sharing a little bit about the IMPACT Consortium and in particular our implementation science work within that consortium. And we just want to give first just a very brief kind of overview of IMPACT. So we're pleased to present this on behalf of our IMPACT Consortium, and you'll see those names on our slides in a moment. Okay, there we go. So just to give a little bit of background, both to Cancer Moonshot, identifying symptom control as a key priority, as well as to the IMPACT Consortium, we know that in cancer care, symptoms are not systematically assessed and reported, and in particular that PROs, while they're having increasing adoption in clinical practice, are certainly far from being used consistently. When they are used, PRO reports also aren't often well linked to the clinical workflow and therefore are often not sort of well integrated into clinical decision making. We also know that symptoms are inadequately managed. There's good epidemiologic data at the national level to support that. And some of this emerges because providers may be unfamiliar with existing clinical guidelines, and resources for symptom management aren't identified or used often just at the point of care. So we really need some systematic efforts to translate what is already known about symptom management into practice, and there are RCTs showing the benefits of integrated symptom assessment and reporting, but implementation science approaches have yet to be really applied to address some of the barriers in promoting the adoption of those integrated systems. And that's what we've been trying to do within IMPACT. So we know the cancer-related symptom burden is substantial. About a third of patients will have 3 or more moderate to severe symptoms. The patients experience multiple concurrent symptoms, and that these are often inadequately treated, as I said. Poorly controlled symptoms impair outcomes. They result in non-adherence, treatment delays, treatment discontinuation, many times emergency room visits, unscheduled hospitalizations, and obviously impairments in physical, social, vocational functioning, and quality of life. So based on all of this, in 2016, the White House call to action led to this National Moonshot Initiative, with the goal of Moonshot overall being to accelerate progress in preventing, diagnosing, and treating cancer. There's a number of recommendations in the Cancer Moonshot report, and I invite you to take a look at that report. But recommendation F was focused on minimizing cancer treatment's debilitating side effects, including accelerating clinical adoption of integrated systems to monitor patient-reported symptoms and provide decision support using implementation science approaches and evidence-based symptom management guidelines. And as you'll see, that's exactly what we're doing in IMPACT. So IMPACT is a transdisciplinary consortium conducting pragmatic trials testing the effectiveness and implementation of EHR integrated electronic systems that allow us to systematically capture patient self-report of symptoms, provide clinicians with evidence-based symptom management guidelines, and offer patients tailored self-management support. You can find out more information about our IMPACT Consortium at the website in these slides. And the slides will be made available, as also Stephanie indicated, there will be a recording of this made available. So just a quick overview of the IMPACT Consortium. It's 3 research centers and a coordinating center. We're testing symptom management interventions that are integrated into the EHR. We are routinely monitoring a set of patient symptoms, and that routine monitoring triggers guideline concordant clinical responses. We will be doing pooled consortium-wide data analyses looking at symptom control, treatment delivery, and healthcare utilization, as well as the effectiveness of this symptom surveillance and management across the cancer continuum and in some underserved populations, in particular older adults, frail adults, and those living in rural environments, as well as individuals who are Spanish speakers. Critical, though, to this discussion is we're also looking at implementation science, specifically the feasibility, acceptability, scalability, and sustainability of these model systems. You can see here the 3 centers. First one is New Impact. That's the center that JD is associated with, based at Northwestern. Symptom is based at Dana-Farber, but crosses 6 health systems in very diverse settings, community and rural settings. And then the E2C2 project, which is based at Mayo, but is recruiting patients who are on treatment in survivorship care and recruiting from rural populations in 3 states. You can see here the consortium members, and I would highlight our coordinating center, which is RTI in the Research Triangle, And you can see here the principal investigators and study teams at all of the other sites, as well as the science officers at the National Cancer Institute and other consultants and staff. In terms of our structure, we have 3 distinct but coordinated research centers that are allowing for both individual and consortium-wide projects. We have common data elements that will be pooled for analyses, and JD and I will talk a little bit more about this. We also have common data elements for the implementation science outcomes as well, too. The coordinating center supports network research to systematize our implementation approaches and help us harmonize key variables. And NCI science officers support each center and provide scientific advice to the consortium. So impact is framed by implementation science principles. And specifically, all of these trials are being deployed in real-world settings. And as such, they are highly pragmatic trials. We're really seeking to try to understand the factors that influence implementation processes and outcomes, things like acceptability, adoption, adaptation, fidelity, and sustainability. We're trying to create a knowledge foundation that will allow for scaling and sustainment of these symptom management approaches in routine cancer care. And we're trying to identify, test, and refine implementation strategies that focus on barriers and facilitators, how best to support champions, how best to provide education and practice facilitation, how to help people restructure their roles, team structures, and workflows, and how to implement and conduct cyclical tests of improvement, implement audit and feedback, and manage clinician performance metrics. You can see here in this slide the members of our implementation science working group, and we have members drawn from across all 3 of the research centers as well as the coordinating center. We also have the project managers for all of the research sites also participating with us in the implementation science working group, because they provide really critical boots on the ground approach to try to help us with some of the scientific pieces that we're looking to accomplish. Our priorities within the Impact Implementation Science Working Group, we've listed them here, and one of the key pieces is to coordinate and synthesize ideas, implementation strategies, data elements, and approaches across all 3 of the centers. We're also trying as a working group to address consortium-related methodologic challenges as they arise. Important for this discussion is that we also from the beginning had it in mind to contribute to methods advances in the implementation science field more generally. We're really blessed to have a very strong working group, and we really felt this was an opportunity for us to contribute to some methods advancements. Specifically, and we'd be glad to talk more about this, we're looking at developing common outcome and process metrics for informatics-based symptom surveillance and management interventions when they're delivered in the context of routine healthcare delivery. We've developed qualitative interview guides and coding books to facilitate the analysis of our qualitative interviews with stakeholders. And we're testing methods for longitudinal tracking of implementation strategies that are used, the refinement of those strategies, the re-implementation of those. And that's really, I think, going to turn out to also be really important to our analyses with respect to understanding the impact of COVID, which of course has hit right in the middle of really our first 18 months of this very, very large project. We're also focusing on understudied implementation science considerations with respect to the reach and access of technology-supported EPRO and symptom management trials. These groups have often been underrepresented in these studies of EPRO systems, specifically older adults, rural populations, those with lower digital literacy and health literacy, and those that are non-English speaking. And we have specific foci within all 3 of the projects to address one or more of those significantly underrepresented groups. And we really think that this will strengthen the generalizability ultimately of our findings. So we'll stop there, and I turn it back to David, who's going to guide us through some questions that he has prepared, and also questions I think that the attendees will have for JD and I.
Yeah, thanks so much for that. And again, we'd love to start seeing in the Q&A field, start submitting your questions as we get going. But we often like to take a step back just to provide, this is wonderful context for the Impact Initiative, and really helpful just to see, not only the two of you working on this, but all of the other experts who are involved in this. But I think we like to start and just get a sense from each of you joining us about sort of your origins, how you got interested in symptom management in cancer, and how you sort of saw the opportunity to braid together implementation science and symptom management in cancer. Maybe JD, can we hear from you first, and then we'll switch back to Sandy?
Sure. So I've had a kind of a longstanding interest in PROs and how we can use them to more effectively kind of address symptoms in healthcare systems for a variety of different conditions. And as you mentioned, Dave, my work, started a lot in mental health, has moved more to chronic disease and infectious disease management and prevention. But when I was approached by David Sella and the really stellar group here at Northwestern about we have a series of projects that are around PRO implementation and symptom management interventions, I was really excited to work on this issue and to get into the cancer care world. So I also saw it as a major opportunity for implementation science. As Sandy mentioned, there's been some, but kind of a limited amount of implementation science applied to this specific area. The opportunity too to work within a very large pragmatic trial that in our case at Northwestern is the Northwestern Medicine healthcare system-wide implementation was something that as a methodologist was pretty hard to resist. So kind of a number of different interests kind of coalesced around this project, and it's been a very fruitful and very interesting work for me, for sure.
Great, Sandy?
So I've been involved in symptom science really across my entire scientific career. It's been a critical focus for nursing. And so I've really been working in symptom science all the way from basic science, looking at what are the mechanisms that contribute to the development of symptoms in various populations, including in unique survivor populations like those with chronic graft-versus-host disease. So I've done basic research looking at cytokine profiles and other kinds of mechanistic underpinnings of symptoms. I've done a lot of work looking at the epidemiology of symptom patterns and how symptoms co-occur in different patient populations. I've studied how to develop interventions then to address those symptoms. And I've also worked on the end of trying to develop guidelines where we synthesize what is known about symptom management for a particular symptom, try to bring that into an evidence-based guideline. And I was one of the first people to develop the guidelines for the Oncology Nursing Society to putting evidence into practice, guidelines for symptom management. But I think as JC said, you can still see a gap, even though we have resources, we have guidelines, and we have those synthesized. How do we actually get them into the workflows and the busy practices of busy clinicians? And I think really importantly, how do we actually do that across settings that may have less or fewer resources to implement these things? How can we use technology to do that, both technology in the EPRO collection piece, but also technology to get guidelines and clinical decision support into practitioners' lab coat pockets. So it's I think for me, symptoms, much of the work that I've done scientifically and directed scientifically really shows that symptoms not only impair quality of life, they make it harder for people to tolerate treatment. It makes it harder for them to go back to work. And it also limits their functional status. And so that's like a huge gateway issue. So I feel like symptom management is just one of the key things that if we can make improvements there, there's really just tremendous kind of distal and follow-on outcomes for that. So for me, I just saw this as a great opportunity that we could really take moonshot that kind of dumped into our lap exactly a priority that I believed, along with others, Ashley Water-Smith, Dr. Paul Jacobson, and really turn this into an RFA and now into the Impact Consortium. So we're very excited. And I think also I give a lot of credit to the National Cancer Institute for recognizing this as a priority and for, working to fund this consortium, very generously so that we can do this important work.
So thanks for that. And I think we can see that in the two of you representing sort of opposite starting points, maybe in one case focusing on implementation science and then seeing the applications of it. And then Sandy, as you said, all of the work that you've done across the sort of research spectrum on symptom science, and then how then does implementation science come in to maximize the value of that. Just so folks know, as you're taking a look at the slides, they've gone from specific to impact to some beautiful nature scenes. We wanted to try and provide some flavor of both where Sandy and JD have resided. And so you saw beautiful mountains, which reflect both of them having a connection to Utah. And here's another one. You also saw the cyclist, the lone cyclist out there, which represents JD's love of cycling and the many bikes that he has, not necessarily right behind him, but behind him at other places.
They are hidden away, David. I took them out of screen, but yeah, they're here.
Okay.
Normally they're well within the screen, Dave. Actually, normally we see like bike parks and.
Sure, right. Yeah, that narrow focus, don't we? So yeah, again, appreciate and thanks so much for those of you who are starting to put in questions. I did want to put just a more general question. We know that impact is still in relatively early days, sort of in the middle, and so obviously not all lessons are learned. But I wonder if each of you could talk about, from the implementation science side, what lessons through this experience you feel like you've learned about implementation science and symptom management in cancer, through impact so far. Anyone want? JD, do you want to start us off?
Yeah, I think having now worked with these diverse groups that all have a kind of shared focus and some shared goals, especially around implementation science of symptom management, I think we really have kind of come to understand the potential contribution of consortium models, and we also, I think, in kind of learning that, we came to appreciate that there really needs to be better articulation of how to actually get the most out of working with a coordinating center and then diverse projects that. We had a number of shared goals because the RFA certainly dictated what we needed to do, but we didn't all propose the same thing, particularly when it came to implementation science methodology. So we spent a good deal of time with our implementation science working group, really right from the beginning, to establish what could end up being cross-project research questions, what could be common data elements and implementation, research outcomes and process measures. And one of the first things that we did is we actually settled on implementation science frameworks that all three research projects were willing to adopt. And the interesting thing is that we all had proposed different determinant frameworks, different process frameworks, and I think two had proposed REAIM, but a third had not. And so we really did try to go across all three projects, figure out which would be the best for us to synergize across. And then we did actually come to consensus, and we presented a poster at the last year's DNI conference that laid out the steps that we followed that we think is a generalizable approach for either multiple projects or within a consortium or whatever it happens to be, where they could figure out what model, what frameworks actually are going to work best to meet the needs of all the projects. I think that was really time well spent because it has made the rest of our tasks within the working group anyway of coordination and synergy much easier. I'll leave it there and let Sandy reflect on this as well.
Great, thanks.
Yeah, I think you said it really well, JD. That we've come out the other side really successfully, and I think in large part we've had great leadership. JD is the chair of our working group, and we've also in the working group had a really collegial atmosphere, a very compromising, listening, trying to look for shared interests. And I think in doing that, we really have borrowed from a very deep tradition of implementation science, which is very team-based and very collegial. But I still agree with JD that going into it a little bit more structured towards the future for these large initiatives will probably save some time. And it also doesn't then really just rely on the goodwill and the collaboration of members to get all of these shared pieces accomplished. It really kind of sets that as a milestone that a group needs to do right out of the bat. we saw that pretty quickly, that we needed to have these things, and we were lucky that there was really good buy-in from the group. But I think more intentionality towards the future is certainly, I think, important. Also, along with that, sort of what are the best practices for executing all of this, and in particular, how best to use coordinating center and the kinds of expertise that are needed within that coordinating center, because they do have a really critical role in the IS space.
So it sounds like a nice combination of thinking mechanically, how do we sort of structure work so as to make the most of these, the individual work that groups are doing and how they can collaborate, and also some of the, within each study, like the use of conceptual frameworks, different ways that you can apply existing tools toward the betterment of each individual project. I'm seeing, and thanks so much to our participants for starting to weigh in with some questions and some really great comments. I'd just like to start picking up the ones that people are wanting to know about. So one of them says, again, with not as much familiarity of all the work that you're doing, if either of you might talk about, maybe whether the work is implementation more focused on a patient alone versus whether the groups are taking a dyadic or a family approach to considering how best to manage symptoms. Either of you want to jump in on that, what level implementation is occurring?
I can start us off, and maybe JD wants to add to this. So I think it is a great question. Predominantly, the approach that is targeted to patient is targeted to patient and not necessarily to the dyad. But I think that the intervention approaches that are being used for the various symptoms don't exclude the involvement of a dyad or family caregivers or others. But when we start thinking about the multiple levels on which this intervention is targeted, it's not only targeted to the patient, but there are obviously some very strong targets within the individual practitioner, within those teams, and then even within the health system itself in terms of providing, like for Northwestern, electronic pathways, for automatic referrals within things like Mayo, providing symptom management nurse experts that are working with each of the teams to overall do practice coaching and try to strengthen each team level's management of symptoms, as well as when they're invited to intervening directly with that patient and family. JD?
No, I totally agree. And I think that there's probably tremendous opportunity for us to expand beyond kind of the patient-centric nature of it to involve families, dyads, and other caregivers and folks who are involved in symptom management outside of the healthcare system. I think that there's a kind of varying degree of that within and across the three projects, but it really isn't explicitly stated, I don't think, in any of them. Most of our materials are internet-based and somewhat patient-driven. So there's nothing that would stop patients from sharing those resources and involving their primary caregivers and caretakers and support systems in those interventions. I think it's just more about do we explicitly encourage that? How do we bring those folks into this, maybe in a more systematic way?
Great, thanks so much for that. Another question is just asking a little bit more about how the impact investigators are assessing barriers and facilitators, whether you're using qualitative or quantitative data, how often, how you try and connect them to specific implementation outcomes. Anything you want to say just about within the initiative, how implementation barriers and facilitators are being looked at?
Yep, I can certainly take that. So we kind of adopted across, again, a consensus approach and some synergies here. We adopted a mixed methods approach where, some of the implementation barriers and facilitators can be drawn from existing data sources or observationally, where they would be essentially quantitative right off the bat. But we have a really heavy focus on qualitative interviewing. So all three of our research centers are using the CFIR interview guide or an adaptation of the CFIR interview guide to capture what we prioritize. And I'm probably speaking out of turn here and will probably be inaccurate, but somewhere in the ballpark of we identified 16 to 18 of the individual barriers and facilitators that all three research centers indicated as medium to high priority. So those are where the focus is. Some centers are assessing more, but we identified these that were highest priority that all centers would evaluate through the CFER interview guide. In terms of actually connecting them to the implementation outcomes, that has not been fully finalized within the implementation science working group, but we have had preliminary discussions of using Laura Damschroeder's -2 to +2 valence coding system for predominantly the qualitative measures of our barriers and facilitators, but also potentially to apply those more broadly to quantitative measures as well, to where we actually could enter those into multivariate models and be able to look at associations either from a univariate or potentially from a latent class or other kind of complicated model to show what kinds of characteristics of the system would actually predict whether or not implementation was going to work. And I think SymPro in particular, which has multiple healthcare systems, is likely to have really great opportunities. And then our synergy, which would involve 8 healthcare systems across all 3 of the research centers, we really could actually potentially shed some really good light on what barriers to facilitators really are related to the success of these different implementation projects.
Sandy, anything to add?
I think that's it's going to be an exciting rich resource for that.
Yeah, and one more thing, so I mentioned too, I just read the question again. We are doing this sort of multiple times. So it's not just a one, time shot at the beginning of the project, because the length of these projects sort of necessitates that we take a continuous look at how the context is changing. So we do have a longitudinal approach with multiple time points, so we can capture some of the dynamic, nature of these healthcare systems, which we know are certainly not going to remain static or the same across our 3 to 5 year projects.
Great, and it sounds like it might take some time if you were going to publish the sort of longitudinal look at it. But someone asked as a follow-up question whether anything on the work that you've done related to barriers has been published as of yet.
It has not. Yeah, our projects are at different stages. So there might be, one of the research centers or maybe a couple of them might have publications of just their data coming out sort of earlier than the others. And then our pooling will take a little bit longer since we have to have all 3 centers get to that point where they've collected at least their baseline barriers and facilitators.
Right, great, thanks.
I think one of the things that's been interesting is that, also even within particular organizations and health systems, so as JD mentioned, Symptom's across like 6 different health systems, but even within our system, the barriers and facilitators are different based on different teams and all of that. So we've also, this is where the strategy tracker has been really important and will continue to be really important, because sometimes various implementation strategies have had to be either revisited or revised. And so being able to use knowledge of barriers and facilitators, and some of it actually happening in real time in some of the sites, that their assessment of barriers and facilitators is actually being used to help tailor what their implementation strategies will be. One example of that is that the assumption for all of this symptom surveillance work being based in the electronic health record is that people are actually registered in the portal and using the electronic health record portal. And one of the projects discovered early on that their pre-project assumptions about that were not just playing out as they thought across all of the different components of the healthcare system. So they had to take a little bit of a back step and look at some implementation strategies focused specifically on that. So it's interesting to me how also the importance of our strategy tracking and tracking that longitudinally. And then of course, with COVID having hit in the middle of this, that kind of turned everything upside down. And so for us being able to track and understand barriers and facilitators at multiple time points is going to be really interesting, because, right, this COVID crisis has also brought along with it a lot more telehealth, and as a real driver has actually brought more registration in the electronic health portals, because people have been forced to do that. But there have been also, so that's been like an accelerator, but there have also been some decelerators. So it's this longitudinal approach, not just a measurement once and kind of done, has been really, again, a real strength of what we're trying to do.
Yeah, and something that I think historically not all implementation studies have included, assumed that maybe on the front end we understand the setting and then we move on. But you're, I think, speaking whether it's COVID specifically or just ongoing dynamism in healthcare and communities of the value of this kind of repeated work. I'm seeing another great question that's asking about the degree to which the different teams are focusing on physician-driven symptom management within the oncologist community, or whether it's more sort of interdisciplinary teams with a range of different providers, and whether the implementation approaches, if it is a range, do the implementation approaches differ, whether you're just focusing on one particular clinical group or a range? Anyone want to jump in on that one?
Sure, I can do this again. So I think that there is variation within each of the research centers about the degree to which different disciplines are involved. Certainly they all are. The implementation approaches do differ by research center, so that in and of itself is certainly present. I think that there are, if I'm remembering correctly, some different kinds of care coordination approaches and different workflow changes that happen based on where a patient might be engaging with different disciplines. So certainly it does seem like there would be, the answer would be yes, that there are different implementation approaches. And certainly the examples that are listed here for psych and social work and rehabilitation, all those folks are certainly involved. In many cases, it really is kind of a care coordination approach, and when you trigger certain symptoms, it triggers recommendations for certain people to be involved that is certainly aligned with who can manage those symptoms. But for the most part, our symptom management is self-management, and so we want to see first if these online available resources can really help people manage their symptoms on their own. PROs that are reported continuously over time will allow us to see that either has or has not happened. And in cases that it hasn't happened, we have procedures in place within each of the centers to actually elevate people's care, which essentially means involving actual face-to-face or other kinds of intervention that involves a healthcare team member, regardless of which discipline they're coming from. But this really is actually one of our kind of questions as well that we're looking to evaluate is, to what extent is it differing by different disciplines, and does it really need to? And it's really healthcare system specific too, because as you'd imagine, our systems operate quite differently and of course very independently.
Sandy, anything?
I think what's interesting is across the sites, and I think that very, very much we are, this is not a physician-centered intervention, that it's really a team-centered one. I agree with JD that for certain symptoms, social work might be the key driver, pharmacy might be another key driver, nursing, rehab medicine, or it may be very much several disciplines kind of intervening to help with something. And then as JD mentioned, there's a stepped care kind of component to that. So you may have sort of the site-specific team, and this is definitely happening in some of the projects where the site-specific team kind of intervenes on the symptom, does their best, but if that symptom is worsening, et cetera, then it kind of gets elevated to a more specialized group to try to offer recommendations and approaches. So that will also be interesting to see. And that's been another implementation challenge, is trying to really look at that workflow. How do you integrate specialized symptom teams into the sort of routine oncology team? And what is their role, and what are some of the best practices for how to do that?
Mm-hmm. Yeah, well, thanks for that. And thanks again to everyone who's getting in these wonderful questions. We'll keep going through them as they come in. And as such, going to jump to the next one, which asks, as an early career researcher, any guidance or advice that you have for someone who's starting in the field of cancer-related symptoms and PROs?
Yeah, I have a very general kind of advice, I guess, for this particular question. I think that the field of implementation science is growing very rapidly, and I think that's pretty clear across all disciplines. In terms of actually cancer symptom management, I think there's tremendous opportunities to leverage some of the successes and some of the things that we've learned actually from other areas into cancer symptom management. So certainly this is not the only area that does PROs. It's not the only place that does symptom management of any sort, whether it's self-management or it's management by healthcare team members. And what it really involves is basically like learning from these other places and borrowing their methods, potentially applying their strategies in new and innovative ways, because we certainly have not figured out how to get universal PROs or screening of patients into healthcare systems, probably to the extent that we would need to really make this highly successful. I think too, we could learn a lot from care coordination and integration models. The field of mental health has done a really good job of kind of specifying what those can look like, and maybe not so much which ones are most effective per se, but there's lots of different options. And so trying to kind of learn from what the broader field has done and apply that here to address some of the unique challenges that this field faces. That's a great place to start to make a mark and potentially really get some innovation points and grants.
I think that's so brilliantly said. That is brilliantly said.
Cool.
The other field I'll highlight, by the way, I think mental health is one, and then the other one, interestingly, is probably older adult care. They don't necessarily call it symptom management, but I think the care delivery models, there's a rich resource there for those. But it's also heart failure is another group that has really focused on how do I do good symptom management and improve the outcomes that way. So those are some analog areas that I think in oncology we can benefit from.
Great, thanks. Another question, what in your opinion are the most important aspects to consider when implementing PROs and symptom management among vulnerable cancer patients with low health literacy? Any thoughts there?
I can get us started with that. I mean, I think it's a really unstudied space, and so I don't know personally that we're really ready for sort of recommendations around best practices. I think we need a lot more qualitative and exploratory work to understand, barriers and facilitators, which may go all the way from language and broadband access, so really foundational kinds of problems, like if measure isn't available in that language, or if you don't have the proper broadband access to complete the electronic PRO. There's a lot of options out there, and I think even looking at technologies like interactive voice response, for example, which really actually, even though it's an older technology, there's some evidence that there's a segment that prefer that. I think this whole area of disparities really needs a focus, and it needs to be, an important focus. And Russ Glasgow, Siobhan Phillips, and Michael Sanchez, when they were all at NCI, did a really nice paper on implementation science for integrating mHealth into research and into practice and policy. And that's a paper I would recommend. We'll ask Stephanie to put that one in the chat. I think it's a good starting place. But this needs a lot more study. And to me, I think it needs actually a lot more careful, thoughtful, qualitative work to understand better the needs and access barriers. JD, you have some other thoughts about that from some of the population.
Yeah, I definitely agree with everything you said, Sandy. I think that, one thing that our group has focused a lot on, and I'm sure it's consistent with the other research centers, is really the usability and human-centered kind of approach to the actual symptom management interventions. So, I think we could probably always do better in getting representative samples and maybe digging deeper into some of these specific groups and making sure that we are meeting their particular needs. But I know that we have really spent a lot of time making sure that our interfaces and our accessibility, assuming they have internet access, that's kind of the first bar. But once they get into those programs, that they're really easy to use and hopefully can be broadly applicable. But again, this is one of those places that I think continuous adaptation and really learning, and then of course the qualitative work and digging deeper into the specific populations can really help us figure out how to make it even better.
Great. Thanks. So we only have a few more minutes, and I'm realizing that we have a few more questions. So maybe I'll ask if one of the first person who wants to jump in. can do so, and then we'll just try and get through them. And again, great discussion, great comments, great questions. One of them being, what have been the challenges? You mentioned mHealth. You know, we think about technology as well. What have been the challenges to integrating PRO symptoms into the EHR from a technology standpoint, but also provider buy-in? Anything come to mind from the impact experience thus far?
Yeah, so we've had a lot of back and forth with our oncologists as well as primary care physicians through other initiatives about which symptoms should actually be assessed. So that there's kind of varying perspective, and people like to prioritize different symptoms and maybe deprioritize other ones for various reasons. So there has been, that does relate to buy-in, and I think that it relates a little bit too to feasibility, because the more, of course, symptoms that you're trying to ask about and potentially asking people to manage could actually, you know, influence infeasibility of this on both the patient side and the healthcare side. I'll leave it there. I can also mention one thing about technology, though. You know, we were kind of fortunate at Northwestern to already have the promise measures, you know, integrated within our EHR. Most of the problems are really around adoption, and as Sandy mentioned, actually getting people registered in the portal, being able to actually access those. But the actual integration process itself had already been done within an Epic EHR. So, you know, we've overcome some of those technological challenges. It's more the technological challenges of getting people into the right place to be able to do the symptom reporting, and potentially some of the back end about how do you access those reports and how do you make those reports really readable, actionable from the healthcare system side.
Thanks for that. And by the way, if you note in the chat, you'll see that Wynn Norton from NCI, from our team, who also works on impact, just put into the chat the link to the paper that Sandy had previously mentioned. So if you haven't taken a look at chat, note that that's where our paper is. Sorry, Sandy, were you going to add something?
Oh, that's okay. Thank you, Wynn, for doing that. Yeah, I mean, I think the other thing that we've a little bit struggled with is some of that workflow. I think everyone does struggle with that. Alerts for severe symptoms. You know, people are already flooded within their EHR with messages and alerts and all kinds of things. And that's a little bit of a rate limiting step, how much user interface tailoring you can do, right, with that. But I think it is an important issue to be sensitive to. And I think we will hopefully at the end of this have some qualitative data that we can provide back to the EHR vendors around some of the things that will enhance adoption. I think that's another thing that we had a little bit of a God incidence in, that all 3 projects are using Epic. That was not something that was in the RFA that all 3 projects had to use, but many times over the last 18 months, I've thought to myself, what would we have really done if that didn't happen? You know, if we were dealing with other, other EHRs, I think our challenges would have been greater for sure in doing everything. It just would have been, you know, much more cumbersome. So I think, though, we do hope that what we learn will be generalizable to the other major vendors that are used in oncology.
Great. Another question that popped up asks, I think, you know, we think about, we've spoken a fair amount about the management, the measurement of the symptoms, and of course then there's the management, or how do we alleviate symptoms where interventions exist. And so one of the questions asks, to what extent on the sort of management side of things are non-pharmacologic, for example, cognitive or behavioral interventions emphasized, and are there specific implementation related challenges from the fact that some of those CBT or other sort of psychosocial or non-pharmacological interventions may be harder to access? Anything on that?
Yeah, that's a great question. I think, you know, we have integrated, at least on the Northwestern side, for our intervention, and I know we drew from some of the NCI funded self-management work already. There is a major integration of best practices. And so for some of those that do involve CBT, you know, certainly those principles and the, you know, specific intervention components are part of these interventions. I think it's the bigger challenge is when there's that stepped care and the elevation of needing potentially, you know, work with a therapist or work with another healthcare professional, that there is, you know, a high degree of variance of availability and access to those within the different healthcare systems that we're working with. So that will be a challenge, I think, for those that need elevated care, and not something we've necessarily cracked yet, but it's a really common challenge, as many of you guys know who work especially in mental health.
And just to broaden it even beyond the mental health piece, but I think rehab disciplines is another space. Access to palliative care is certainly pretty broad, but access to things like acupuncture can be very, very challenging. And then the whole COVID piece has really affected people's access and what they're willing to access or go be referred for, like rehab. I think it's a really brilliant question, and it's something we are going to try to understand is to what extent, when these things are recommended to people, do people fail to pursue them, and why? Is it an access barrier? Is it a reimbursement barrier? That's the other really big piece. There's so much of this, as you know, it's not covered, or there's really constrained, like you're entitled to 10 physical therapy visits per year. And once you've capped out on that, that's it. You're paying the rest out of pocket. So that underinsurance piece, and then the access for particularly specialized types of therapies. And I don't think these projects will really be able to crack any of that. But what I hope we will do is surface, why do people have barriers in accessing when something's been recommended to them and it's guideline based? What hampers them, and what can we do to address those kind of barriers? I think it's a really important question.
Yeah, and likely the types of things that over the longer term of impact, there may be a chance to explore some of those and even add on some of the other questions talking about sort of differences by cancer site, or the different receptivities of team members and how one tries to optimize team-based care. I wonder, given that we're at the top of the hour, but I wanted to kind of slide in one question, because recognizing that we still have a number of participants who may be saying, is there any way that they can add to this broader effort of how symptom management and implementation science can come together? So just any final thoughts about, for someone who's listening to this and saying, wow, this is great, I understand that these groups are in the middle of a lot of this work, but is there a way that I might be able to contribute to the overall cause? Any answer for that?
Yeah, I had one idea, which, one of our, one of the biggest, things that we want to have as kind of a product from this work is we want to have a generalizable implementation blueprint. I mean, we want to have guidance that's relatively specific, but also generalizable across health systems, as Sandy mentioned, for other EMR systems as well. And so I think it's going to be pretty imperative for us, because we do have only 3 research centers, to likely engage additional both healthcare system stakeholders, but also implementation researchers to really speak to the generalizability, the feasibility, and the actual potential likelihood that somebody could actually do this in healthcare systems other than those who are involved in the Impact Consortium. So that's probably late stage, once we have once we have data and we have a proposal. But I think there's probably ways that we could certainly involve the broader community in that, and we will need to.
I think to end on that, I think symptom researchers who are developing interventions really can be designing those interventions with dissemination and implementation in mind right from the beginning.
Absolutely. And
really beginning to think through, well, what are the key questions? I was just consulting with someone yesterday with Dr. Frank Perna about exercise interventions and how we can implement those, and really trying to understand then in those effectiveness and efficacy studies, what are the implementation pieces? What are going to be the barriers to people accessing this in their home communities? What's the difficulty around scaling? What is the knowledge that I need to have? So building that in, and by and large, our symptom management interventions don't do that. They really are studying in very purified kind of populations with, a highly manualized intervention with very little knowledge about how that intervention can be changed for different contexts and still preserve the effectiveness. Very little knowledge about how that can be disseminated out to various underrepresented populations. That's the other piece, is that we develop most of these interventions in English, in big cancer centers, in urban, suburban kinds of environments, and many times we develop them for face-to-face. Now, COVID has turned that on its head, so I think there will be some things, but I don't know that COVID will have done the designing for implementation, and that probably needs to happen in all of our symptom management intervention studies.
It sounds like, in summary, that while there's such amazing work going on within the initiative, there's any number of opportunities to extend upon that work So we'd look to those of you who are looking for that next thing that you want to do to really help lift all boats as much as possible. Again, thanks so much to JD and Sandy for representing the larger impact group. Thanks to our colleagues at NCI and, of course, to the grantees at the 3 sites, as well as the coordinating center for all of their work. And again, this is something that we see as just really important. How do we not only see the value of the investments that we can get out of some of these moonshot initiatives, but how do they fit within our broader implementation science community? Next week, hopefully many of you will be joining us for the Implementation Science Consortium in Cancer, where we are thinking about that big tent, and impact, of course, is part of that tent, as are many of you and many others who are not joining us today. So thanks so much. As you can see here, and actually maybe I'll turn it back to Stephanie to close us out, but just thank you to Sandy and JD, to Win for joining, and to everyone for listening in.
Yeah, thank you, David.
Thank you.
So Stephanie, you want to
thank you again. Yeah, thank you again for joining us and for your patience before we got started a little bit today. An archive of today's session will be made available shortly on the IS website, and that is all we have for today. So thank you again, and you may disconnect at this time.